I am a consultant for Quest Diagnostics as my main relevant disclosure, and we are now going to start the presentation with an outline of learning objectives. We're going to have a brief overview of the hepatitis B viral disease, talk about laboratory markers and their significance, and then focus heavily on the role on S-antigen quantitative assay, both in the setting of interferon therapy, nucleoside and nucleotide analog, and also talk about S-antigen in drug development, because there's many new medications coming out for hepatitis B, we hope, in the next 5 years. And we'll talk about how to integrate that testing in drug development, which then would enter your practice. All right, hepatitis B overview. This is a virus, a DNA virus that's incurable, that is surrounded by S-antigen and core antigen. The core antigen forms a capsid, and the surface antigen is part of the viral envelope. Inside the viral particle is the viral DNA. Those are the major components. And of course, there's an E antigen, which is related to the core antigen in the sense that it's a partial protein that is also secreted or made by the hepatitis B virus that's measured clinically. The body, of course, makes antibodies to core and to E and to surface antigen, and we measure those also in clinical practice. This is a diagram of the hepatitis B life cycle. It comes into the cell through attachment, through what's called the NTCP receptor, goes into the liver cell, uncoats, goes into the nucleus, forms cccDNA, and that's why it's incurable. It moves back to the cytoplasm with RNA, different RNA lengths, pregenomic RNA, becomes encapsulated, and then becomes enveloped, and then is secreted. So making this simple, there's many, many other complex steps, but this is the basic life cycle of the hepatitis B virus. Now this is a graph that almost everybody has seen during their training or during practice, and talking about acute and then chronic disease. And usually early, E antigen is positive, indicating wild-type infection, and then they become E antibody positive. E antigen disappears either with viral suppression or as the virus mutates to what's called the pre-core mutant. And in that setting, there's no E antigen, but there's ongoing viral replication. Surface antigen is produced, of course, during that life of the virus as chronic disease is tested and documented. Core antibody is also positive. We'll talk maybe a little bit about core antibody during this presentation. Is a cure possible? Yes, in the future, but today hepatitis B is incurable. As we mentioned, it's making E antigen, surface antigen, both of which modulate and manipulate the immune system. In the nucleus is cccDNA, which is a stable template. You'd have to basically kill every liver cell to cure this virus, and of course, then you wouldn't have a liver left, and you wouldn't have a patient who's alive. So maybe they'd get a liver transplant. Maybe there are settings where cccDNA is completely cleared with a liver transplant, or maybe in the setting of fulminant liver disease. But for the time being, this is an incurable disease. And once a patient has core antibody, they have core antibody typically for their lifetime, and they always have residual HBV DNA in their liver cells. So there's no such thing as natural immunity, which is found on a variety of different websites, including the CDC website, but we consider that an oxymoron. And we talk about reactivation, we talk about latency, we talk about patients don't need vaccine if they're core positive. Now this is a slide that talks about the 5 phases of chronic hepatitis B. I'm not going to read through each one of these bullets because this is fairly complicated, but there's this early phase that we call high replicative, low inflammatory, normal ALT, low ALT, high HBV DNA. We used to call this immune tolerance, but it's really not a tolerant phase. There's a training of the immune system. Then we have wild type infection with E antigen positive. We have immune control, inactive surface antigen carrier. There's no replication. Then there's E negative with moderate to high DNA levels. And then finally S clearance, but not a cure. It just means S antigen is cleared from the serum. The natural history of chronic hepatitis B is marked by the surface antigen. If it's positive, they've got either acute or chronic disease. 99.9% of the patients you see will have chronic hepatitis B disease. Surface antigen clearance is our highly desirable treatment endpoint today, although this rarely happens with either interferon or nucleoside or nucleotide analogs. But when you clear S antigen, there's an improvement in survival, lower rates of liver cancer, lower rates of liver decompensation. And we're using a term now called a functional cure when patients clear S antigen. And we're talking about S antigen natural clearance occurring in about 0.5% of patients with vertically transmitted hepatitis B, which is typically the Asian population, or 2% in adult acquired hepatitis B, which you might find in the U.S. or Western Europe. Another diagram on the natural history of hepatitis B, knowing that the majority of hepatitis B in the world is perinatally transmitted from mother to child. Most patients then enter this high replication, low inflammation stage. Horizontal transmission usually is E antigen positive, wild type infection with immune active disease. And then we have these transitional states to immune control, E negative disease, and then S clearance. Now, the surface antigen titer has some correlation to HBV DNA quantification, but I want to highlight here that these tests are complementary. They're to be used together. And you're going to be using Quant-S with Quant HBV DNA, E antigen status, E antibody status, alpha-fetoprotein, ALT, elastography, platelet count, abdominal imaging. There's at least 7 major tests, and actually 11 tests that I do on all of my hepatitis B patients to stage their disease. But I'm putting Quant-S in that top tier of tools to stage patients in their first testing process when I see them in clinic. And then I have a baseline Quant-S to look at what's happening either naturally or with therapy during treatment that I may institute for their care. There's another graph that looks at log HBsAg with some correlation with HBV DNA, but at the upper and lower boundaries of the HBV DNA quantification, you can see a pretty wide spread. And now we're going to talk a little bit about how we tighten up our assessment of patients and how Quant-S can help us focus on those patients and provide, I think, better care. Now, this slide is very important. We've got our immune trained or tolerance in the upper left with very high S antigen status. So if a patient's in a gray zone, you're not quite sure where they are, their ALT may not be healthy. Let's say a woman should be less than 19, but her ALT is in the 26 range. But you've got a super high S antigen quant. They're probably in that immune trained stage, that low inflammatory high replication. Now we move to immune clearance. We're starting to see more and more patients with lower S quant, low replicative phase, very low S antigen quantification, and E antigen negative, we're seeing patients in that mid-range. So if the labs aren't clear, the ALT is not absolutely clear, you can be looking at the Quant-S to help stage those patients and define where they are. And this helps you decide who to start treatment, who you might want to wait, who you might want to monitor. Another slide looking at that baseline Quant-S versus inactive and active disease. Let's look at the lower 3 lines. DNA, let's say, is 800. ALTs in the healthy range or just slightly above the healthy range. And we're going to be talking about that patient probably being an inactive carrier. That's what the AC designates. Now we're looking across this with higher Quant-S levels, and they're active carriers. That's the AC designation. Active carrier 1, active carrier 2 with a little higher level of liver disease and higher level of risk of progression, and you may want to institute therapy in those individuals. Of course, this correlates with DNA level at some level of correlation. Here's another slide talking about HBV disease phases and looking at Quant-S and combining that Quant-S with Quant HBV DNA. Now on this slide, we're just giving you references and a number of patients, sensitivity and specificity, and predictive value for something such as reactivation. Now patients naturally can suppress virus, but about 15% per year will reactivate. And that risk of reactivation correlates with the S antigen quantification from one publication. Now, this had 30 patients. It's a relatively low number, but this can help you guide therapy, guide monitoring of patients, how frequently you may want to do follow-up testing. So a lot of data on this slide, but just gives references and NPV, negative predictive value, positive predictive value, sensitivity, and specificity. Let's go into a little bit more detail about laboratory markers in hepatitis B infection. Now, this is a slide that has what I assess all my hepatitis B patients for when I'm in clinic. Now, I don't do delta testing on every hepatitis B patient, but I'm thinking about it on anybody who has adult-acquired hepatitis B or anybody with advanced liver disease, just as an example. Or if I've got somebody who's E antigen positive, but they're 35 years old, I will check core and pre-core. But you can see that QuantS has a prominent role in assessing those patients for their disease stage, and I'm thinking about future risk for cancer, whether I'm going to start therapy, whether I'm going to be doing surveillance with lab testing every 3 or every 6 months. So this slide is very important for you to come back to and reference and really keep on your desktop in your hepatitis B patient assessment. Now here we're talking about application of QuantS. Here are some proposals: natural history and during therapy. And we're going to get into more detail here about pegylated interferon and nucleoside and nucleotide analogs and where is that data. Application and benefits are highlighted on this slide, and you might use it as a stopping rule if you do use interferon in your practice, which is pretty rare, or more likely if I have a patient on a nuke, such as entecavir or tenofovir, or now TAF, which is a new form of tenofovir that's on the market, I'll be able to use QuantS to say whether they're going to have a chance of clearing S antigen on that nuke if the S antigen is declining. Now, what about mother-to-child transmission? We brought up initially that that's the most common way for people to become infected globally. And the higher the QuantS, that's what this graph is showing, the higher the risk of transmission to the infant. Typically, we've been using HBV DNA level, and we have an absolute cutoff, absolute meaning in the guidelines, of 200,000 IU for quantitative HBV DNA for high risk versus low risk. Well, that's not a perfect number. It's a simple number, but it's not a perfect number. And QuantS could come into the mix if you have a patient who's got an HBV DNA level, say of 200,000, but they're E antigen negative. And if their QuantS is low, the risk of transmission is going to be much, much lower, and you may not institute nuke therapy, such as tenofovir, during the 3rd trimester. So this is a very interesting publication that came out. Now, if patients have good immune control, that means their immune system is controlling that virus, they may have a low level of S antigen, and the S antigen may be declining over time. If that S antigen is declining on its own without intervention, without a therapy, you may decide that you're not going to start therapy. You're going to see if that patient's going to S clear on their own naturally. Here's another S antigen quant levels as an indication of immune control. And it talks about the different log levels of that immune control status, both for QuantS and quant HBV DNA, and then again back to risk of reactivation. And this number around 3 log IU, 1,000 range, is an interesting cutoff for that level of really saying somebody's got a good immune control and they may not need therapy at that time. Now, what about patients who change their S antigen? What the data on this slide shows is that if the S antigen goes down by 1 log in E antigen negative patients, that patient may actually undergo natural S antigen loss. There's a lot of data on this slide, but look at the right graph and looking at that increasing chance of S loss, that is an indication that with a log reduction over time, long-term follow-up, that patient may clear S antigen on their own. So that dynamic naturally can help describe that patient's future events. Another slide on natural history of HBV, looking at QuantS. Looking at quant S combined with HBV DNA level, more data, more references for your future review, but that quant S level can help describe the natural history of your patient, and you can make decisions about whether to start therapy and frequency of monitoring. E-antigen seroconversion. So we want our patients who have e-antigen positive disease to lose e-antigen. That could be naturally or with therapy. Now, lower the S antigen, and when patients lose e-antigen, their liver cancer risk is lower. That's basically what this data is showing in the right graph on this table. So we like the DNA level to be under 2,000. We like the ALT to be less than 40. That's not healthy, but that's normal at a number of labs. And here we have a cutoff of S antigen less than 1,000. You can see a very, very substantial decrement in decreased future liver cancer risk. Now, quant S on its own doesn't always decrease when patients lose e-antigen. So it really is an individualized patient status. When patients lose e-antigen, that could indicate moving to immune control and that immune clearance, or they could be converting to E-negative disease. So you're going to be combining quant S with monitoring their qualitative e-antigen status. We don't have a quant e-antigen test in the United States, at least not yet. Now this is looking at e-antigen negative patients followed up for 8 years. Now, will somebody remain inactive? And the chance of remaining inactive is even better when their S antigen is less than 100. Less than 100, extremely low risk of reactivation. S antigen over 1,000, very high risk of reactivation. So you're going to monitor that patient potentially every 3 months. They reactivate. Again, this is when a patient's not on therapy. Then you would consider instituting a nuke depending on their ALT and looking at their liver disease status by lab testing or by imaging. This is a Taiwanese study in E-negative patients with HBV DNA levels low, under 2,000, followed for over 13 years. When you combine S antigen levels with HBV DNA quant and ALT, you can help predict the risk of disease progression in those low patients. So let's say you have a patient with an HBV DNA level of 100 and their ALT is just above the upper limits of healthy, let's say for a man, 32, 35. And you're not sure what to do with that patient. Do you start nuke or not? And the guidelines would say no. But if the S antigen level was over 1,000, and let's say imaging suggested hepatocellular disease, then I would institute a nuke. So I'm bringing quant S in, especially for your gray zone patients, to decide what to do with those individuals. Do you start therapy or not? What's the risk of progressive liver disease? Back to the sad news. In Western adults, the chance of a patient naturally clearing S on their own, as we mentioned earlier, is in the 2% range. Some it's even lower, but you can see from the Alaska data, it's in the 1% to 0.5% range. But that's because in Alaska, most individuals historically had vertically acquired hepatitis B. It followed more of an Asian pattern, although there was some horizontal transmission in Canada as well. You move to Brazil, that's going to be mostly adult-acquired or horizontally acquired hepatitis B. And here we have a 2% range. But there are other patients that clear on their own, especially if they have higher ALTs, lower quant DNA levels. But that quant S trajectory is going to help define what direction they go, where they're going. Asian adults, much lower chance of S clearance, but there is a chance of S clearance, and we had a paper recently, at least an abstract from our practice in San Jose, in a largely Vietnamese population, where we had a 5% chance of S loss. And there were different predictors of that S loss, and we'll be looking at quant S in that population, in the Vietnamese population, to help define its role in that special group. Spontaneous seroclearance in asymptomatic carriers in highly endemic areas. When does that S clearance usually take place? And here we have a peak between age 40 and age 55. If you're younger than that, we don't see much S clearance. You're older than that, if you haven't cleared S, you probably won't clear S. So there is an age distribution of S clearance. Predictive factors of S clearance, again, we're going to highlight the quantitative S antigen. Declining or low levels of S antigen are part of that predictive matrix, that grid that you're going to put together for your patients. Okay, quant S levels predict spontaneous S seroclearance. This is from Dr. Y.C. Chen, published in 2012. And again, cutoffs at 200 or 100 had both a good positive and negative predictive value. So you're over 100 or 200, better negative predictive value. You're under 200, 100, better positive predictive value. Quant S levels, here is seroclearance in Asians. Again, we're looking at 100 cutoff and 1,000 cutoff. The lower the S antigen levels, the higher the chance of natural S clearance. This is what's called the albatross studies, S clearance in adult-acquired hepatitis B. Again, we can use this in both vertically transmitted and adult-acquired hepatitis B. And the quant S level here, they're talking about a 5,000 cutoff, looking at different chances, yes, no, of clearance. And there was also some influence by genotype that had to do with this, and of course, low HBV DNA levels. But the quant S had a prediction and a p-value of less than 0.001 of naturally clearing S antigen. This is E-negative patients, just to highlight that part. Spontaneous S clearance and development of HCC. So this is bringing us back not just to the quant S number, but why we want S antigen to disappear. They still have hepatitis B in their liver, of course. This is incurable, but when you get to dysfunctional cure, your chance of liver cancer drops dramatically. So this is just basically the home run in hepatitis B management. Let's talk now a little bit more about monitoring during treatment. We've done lots and lots of natural history discussions here, and we're going to move through this next section, briefly talking about interferon therapy. If you use interferon, which isn't used much in the United States, if you use interferon, you can lose S antigen, and I usually quote to my patients 10 to 15% chance. But there are some studies, including studies that were done in Italy, where that S clearance rate was much higher than with controls who were untreated. Now the difference, sometimes it's a twofold change, and sometimes it's a 3- or 4-fold change. Unfortunately, people just don't like injection therapy with the side effects of interferon. And in the U.S., we haven't had Quant S available. And Quant S at 3 months into treatment can help define who's going to respond and who's not, whether you continue or you stop treatment, called stopping rules. So now that we have Quant S, interferon therapy use may increase slightly. Here is data from UN, from Hong Kong, and Lin from Taiwan, showing that even in Asian patients, you can go from this 0.5% up to 3% to get S clearance. But it's a lot of work for a low rate of functional cure. This is recent data, 2010 from Dr. Chu. Now, in e-antigen positive patients, you can see in responders a beautiful decline in S antigen. And you can follow those patients out long-term and show the S antigen decline or clearance. Here on the percent side, on the right side, E loss and S loss, you're looking at an S antigen titer at week 12 of 1,500. So 3 months into interferon therapy, you can basically say yes or no, they're going to clear E. But better yet, yes or no, that they're going to clear S. This is by Sonnenfeld in hepatology. This is a Western European study, mostly adult-acquired hepatitis B, but some vertical transmission. Here's more e-antigen positive data with PEG interferon, defining non-response, relapse, and patients with sustained virologic response, loss of S antigen. At 3 months, you really want to see a multi-log decline in these e-antigen positive patients on interferon to say they have a chance of losing S. More on e-antigen positive patients. pegylated interferon, you see this change in the spread that starts widening between 3 and 6 months with HBV DNA, but it's not as profound as you see in the right box where you're looking at log S reduction. 3 months really separates out patients whether they're going to get S loss or not. What about end of treatment outcomes and S clearance with PEG interferon? We're going to look basically here at the top box, S antigen level at week 48. If that patient has reached 10 IUs, remember the sensitivity of the qual and quant S is down to 0.05 IUs. That's 0.05 IUs. But if you're under 10, you've got this very, very high chance of losing S antigen, about 50%. So I would be checking quant S at 3 months and quant S at week 48, and then help describe to the patient what's going to happen to them long term, whether I'd want to say come in with a nuke or not if they're not having an S decline. Tenofovir. This is really one of our top first-line drugs. And basically, this is just talking about tenofovir and what's happening to the probability of S loss on treatment. This is not quant. This is just saying yes or no. And we're following out patients almost to 400 weeks. We're getting up to about a 13% chance of S loss. 1 pill, once a day, minimal side effects with this medication. But it still isn't a great number, and that's why we're developing new drugs for hepatitis B. We want this to be 50%. But at least with our oral therapy, there's a chance. And in this study, the quant S antigen level at baseline helped predict who was going to clear. A rapid S decline in E antigen patients on tenofovir predicted who was going to clear. So you've got somebody on tenofovir, you're monitoring their S antigen status. It's much better, as you can see in the left, which is quant S, from the right graph, which is HBV DNA levels, because basically everybody on tenofovir suppresses HBV DNA. Most patients clear HBV DNA, but only a subset have S decline, which would then predict S clearance. A little bit more here in terms of the quant S. Let's look at the third green box from the left. Go down to the bottom. It says S antigen greater than 4.5 logs. This is kind of interesting because this is the patient population who had a high quant S at baseline. For some reason, the higher the quant S at baseline, the higher the chance of S clearance long term. This is different than what we saw with interferon data, where the lower the S antigen at baseline, I didn't show this data, but the lower the S antigen at baseline helped predict interferon-induced S antigen loss. And why it's discrepant between interferon and nuke, we don't know, but here's the fact. But here, higher inflammatory score, HBV DNA levels, and genotype also help predict S loss, S clearance at year 4 of treatment. Now let's look at the kinetics. This is what we call a spaghetti graph. But you can see that the patients who clear S antigen typically had a significant decline in S antigen early or moderately early in this treatment course. Now, this was an interesting study because a subset of patients were on adefovir, a drug that we don't use anymore for hepatitis B management. And when you switch from adefovir to tenofovir, you can see that you pick up another group of patients in the orange lines who are going to clear S antigen. So patients and providers often ask me, am I using lamivudine? If they have somebody on lamivudine or somebody on adefovir, what do? I switch everybody to first-line therapy because the rates of S clearance with lamivudine and adefovir are dismal. At least with tenofovir or entecavir, we have a chance. This is a discussion about long-term antiviral therapy for hepatitis B in a real-world setting. We like real-world data, and we published this paper in an abstract looking at about 1,000 patients in a GI-based practice in Northern California, and it was almost 99% Asian and had about an 87-month follow-up. We did have significant S loss in this patient population, and the cohort characteristics are highlighted on the right side, baseline information. 62% of these patients were cirrhotic. So what did we show in this abstract? that we could get S loss, as I mentioned earlier, at a 5% rate in our Asian patient population. ALT normalization also occurred, undetectable HBV DNA in most patients. What's interesting here is that about 10% of patients lost S but still had detectable HBV DNA. This just highlights that you need to be looking at your patients from their S antigen, quant S antigen perspective, and monitoring DNA. If their DNA remains positive but they lose S, you need to continue to monitor those patients more closely. Now this is talking again about what groups, the higher the ALT, the higher the chance of S loss. Cirrhotic patients could lose S, but the patients without cirrhosis did better. And interestingly, older age had a slightly higher rate of S loss, and men had a slightly higher rate of S loss. Predictors of S antigen loss now in NUC-treated patients. This is a combined table from 3 different studies. And we're going to drop down now to the orange bars, or the higher quant S levels, as we mentioned earlier, help predict S loss. But more importantly, it's the dynamic. You need about a half log reduction at week 12 or 24, or E antigen negative by week 24 in the tenofovir group to say that they had a higher chance of S loss. So it's really hard to lose S, say, if your E antigen is remaining positive. So we have a matrix. We have a series of lab tests, baseline, and on treatment that we're going to use for monitoring our patients. This is a tenofovir study where they combine tenofovir with pegylated interferon in patients with significant liver disease. I'm not going to go into all the different parts of the study design, but I'm just going to say that there was a hint that combination therapy resulted in a higher rate of S loss, but you really have to look at patient characteristics. And here we're going to basically say the baseline predictors of HBV DNA decline at a p-value of 0.001 included a low quant S level at baseline. So what predicted quant S decline? Genotype A. Interestingly here, high S antigen and high HBV DNA levels at baseline. So you look at this, you have to look at your therapy, and you have to look at the dynamic on treatment to define who's likely to lose S antigen. Now, what about risk of liver cancer during treatment? This is kind of an interesting study. Higher the S antigen, over 2,000, much higher risk of HCC. Look at the difference here. S antigen less than 2,000, negligible risk. S antigen over 2,000 during this study, we're talking about a higher risk. Now we're combining that with HBV DNA levels. So if you've got a low S antigen, it doesn't really matter what your HBV DNA level is. If you have a high S antigen, the higher the DNA level, the higher the risk of HCC. What about ALT flares? This is kind of an interesting study. ALT flares here did help predict a decrease in S antigen. So if you see an ALT increase during your patient management, you should really continue whatever you're doing, but be able to tell the patient there's a higher chance of having S loss and S decline during that flare. S antigen loss in E positive and E negative patients, this is just reviewing what happens. Left cluster is our NUCs, right cluster is pegylated interferon, and we have 5 to 10% chance with NUCs, and we have an 8 to 15% chance of S loss with interferon therapy. And even combination therapy may be slightly higher, although that's still not golden. What about drug development? As we mentioned earlier, there's many, many new medications being developed for hepatitis B. We're looking for hepatitis B cure like we have with hepatitis C, but we're not there yet. And the AASLD convened a program in Virginia in 2016, and this was an interesting study where they participants basically voted and said, what did they expect during drug development, especially for phase 2 studies? Half the audience stated that they need to see a 1 log decline in more than 50% of patients during a phase 2 study to move that drug forward to, say, phase 3. Now, some of the participants wanted S loss also, but that's probably not really realistic in a phase 2 study, especially if you're looking at early data. It's going to be that S decline that's going to be so important. So every study that I know of is looking at S antigen, quant S antigen levels at 1-month intervals during drug development. So this is really the standard for drug development today. Again, we're talking about phase 3 studies. Now we're going to be moving yes, we want S decline, but really S loss, and we want S loss in over 30% of patients in our phase 3 studies. And we really want our phase 3 study treatment duration, this is now my expert opinion, to be a year or less. That's going to really, I think, impart a much higher level of patient and provider engagement. So we're coming up here, so we have some time for Q&A. We're going to move through a summary here. Spontaneous S antigen clearance, 0.5 to 2%. The 1 to 2% is really more data for adult-acquired hepatitis B, 0.5% in vertically acquired patients who typically are from the Asia-Pacific region. Now we're going to talk about S seroclearance with antiviral therapy. Western patients do better than Asian patients, but as I showed you, in an Asian patient population from our group in San Jose, we had a 5% chance of S loss, and that's hopefully going to be accepted in a peer-reviewed publication very soon. Quant S should be determined, in my opinion, annually, but you'd be looking at it every 2 to 3 years to look at S seroclearance in your patients who are carriers, meaning patients who you may not be instituting therapy specifically. Now, when you clear S antigen, the good news is these patients have a lower risk of decompensation and a lower risk of cancer. Quant S antigen helps you stage their disease. What phase, what state are they in? Future risk of liver cancer, probability of viral clearance, that's that functional cure, that's clearance. What's the response, the nukes? Do you have a reason to stop interferon at 3 months if they haven't reached a specific threshold? What's the risk of HBV mother-to-child transmission? Drug development for an HBV cure is ongoing. And I also like S antigen during treatment, especially with nukes, to enhance patient compliance. If the decline is taking place, you really can boost that patient's confidence that they may be clearing S, say, on a nuke therapy. Conversely, if the S antigen is not clearing, but the DNA has cleared, you're DNA negative, but S antigen, say, is running 2,000 to 5,000, then you're going to be saying, oh my gosh, we need to keep you on therapy, because if we stop treatment, you have a substantial chance of relapse. And then, of course, you could have a relapse, you could have a flare, you could have decompensation in that patient. So it really works in all patients to help with compliance. I think that's a very important issue. And I think we're going to now turn it back over to Melissa and the team at Quest. I want to thank Quest for bringing this LDT test to the setting that we can use in our practice in the U.S. This is available in over 70 countries, and I think most recently I counted 100 countries worldwide that we can get Quant S. Now we have it available in the U.S. It's really nice to be heading towards the engine and not on the caboose of testing. Thank you so much for participating today.
Thank you so much, Dr. Gish. We have a number of questions that have come in through chat and Q&A, which we will jump right to after we let Maisel review the instructions for live questions. Are you there, Maisel?
Yes, Ms. Hudson. And participants, we will now begin the question and answer session. If you would like to ask a question, please press star and then 1. Please unmute your phone and record your name clearly when prompted. Your name is needed to present your question, and to cancel your request, you may press star and then 2. And let's wait a moment for the first question.
Well, while we're waiting to see if any live come in, Dr. Gish, we've had a number, as I mentioned, come in. I'll just start giving them to you. So first up is, any prediction when the FDA will approve in the United States the Quant Hepatitis B surface antigen test?
So this is a great question. In the United States, we have two pathways forward to get tests to the clinic. One is this LDT, or laboratory determined test, and this is typically a test that's CLIA approved, and that may depend even on state-by-state approval. But there are many tests that you and I use every day that aren't FDA cleared. And we're going to use the word cleared, not approved, because that's what the FDA terminology is. But cleared and approved are probably interchangeable. There are two assays that are used throughout the world that are, say, CE marked, and both Roche and Abbott have those assays. We are hoping that Roche and Abbott will work and move forward to get FDA clearance for their tests in the United States. And then what may happen, Quest would use their LDT currently, but if there's an FDA cleared test, Quest may actually institute one, the other, or both of those FDA cleared tests in their lab. That would be up to Quest to decide, so I'm just putting, again, my expert opinion out there. But for the time being, we have a very reliable LDT test that's available in the United States for you to use in your practice.
Thank you. How about co-infections between hepatitis B and hepatitis C? Is the quant antigen as important?
That's a great question, and I have to say we don't have data on that co-infection with either Delta. There's probably, I'm going to say 0, but there's not a lot of data. In Delta, I think the quant S tends to run pretty low. But that's a good place for research and one that we can move forward at our national and international meetings. Excellent thought.
What proportion of hepatitis B infected patients naturally clear circulating hepatitis B surface antigen qualitatively? Will they relapse to a positive hepatitis B surface antigen state later in life?
So that's a great question, and we're saying 0.5% in vertically transmitted, up to 2% in adult transmitted hepatitis B naturally clear S antigen. The relapse rate, either naturally or post-therapy, is very low. And I'd quote the lifetime risk of seroreversion with natural clearance to be under 5%, and seroreversion with nukes to be well under 15%. So it's very low. So what you would do, once someone clears S antigen, is you would monitor them annually for at least 3 years to document they've lost S and they've maintained S loss for 3 years. Then probably you don't need to check again unless they have an ALT increase.
Thank you. Healthy people who are persistent carriers of the surface antigen may have no laboratory evidence of hepatitis, whereas others have biochemical or histological filings of chronic liver disease. Is this because the surface antigen is detectable in the serum? Is this because it's detectable in the serum before liver function tests abnormal, or before development of clinical features of hepatitis?
All right, this is a fantastic question because we're going to change your terminology today for the rest of your life. Number one, we no longer use the word healthy carrier because that's an oxymoron. If you are carrying hepatitis B, you can't be healthy. So we're going to talk about these different phases of diseases, but we won't use the word healthy carrier anymore. The next terminology change is the word liver function test. AST and ALT are not liver function tests. Now, I know many of you have been using that term for probably most of your career, but the new world, and the world is changing, as you know. ALT and AST are liver enzymes. They do not denote or mark liver function. Liver function is denoted by bilirubin, albumin, or INR. Those are liver function tests. AST, ALT, GGT, alkaline phosphatase are liver enzymes. Now, liver enzymes, you might check twice a year. But remember, there's 365 days in the year, and you're only getting an ALT on 2 days of the year. So you're missing 363 days where the ALT might be increased. So if you want to determine if people have liver disease or not, you have to stage their liver disease by using other tests. Now, when people have low ALTs, healthy meaning an ALT in a woman less than 20, ALT less than 30 in a man, forget what your lab calls normal. Might be normal, but it's not healthy. you need to stage their liver disease. And back in the former times, we would just say, get a liver biopsy. But we rarely do liver biopsies. We will calculate an APRI or FIB-4 score. Those are scores available online looking at enzymes and platelet counts. But better yet, in people with normal ALT and AST or healthy ALT and AST, you need to image their liver. Now, liver imaging can be simple. You get a full abdominal ultrasound and ask for a spleen size and portal vein diameter. And at more sophisticated geographic locations, you're going to get something called transient elastography, or you may order through Quest or your local lab something called FibroSure or FibroTest, which is a blood test for liver damage. But in people with normal ALTs, again, less than 20 in women, less than 30 in men, imaging is your best friend. Elastography is the best way to image the liver, which is a whole other discussion, but it's basically a way to stage fibrosis. And if you have normal elastography, normal ultrasound, and normal ALT, healthy ALT, you can say that person is an inactive carrier, provided that their DNA is very low or undetectable, and their S antigen quant is low. So remember this matrix. You need multiple tests to determine stage, state, phase of disease for your patient, and whether they have a low risk of progression or a high risk. Again, banish that word healthy carrier. It's an oxymoron like jumbo shrimp.
Thank you. Dr. Gish, could you please, somebody just asked, could you repeat those tests that are the liver function tests again? INR, bilirubin, and then the chatter is asking what the third.
Albumin is the third liver function test that you would look at in your patients. And bilirubin is your best liver function test, and the direct bilirubin is the best of the best. A healthy direct bilirubin in a healthy person or a person with minimal liver disease who's not necessarily healthy but has, say, quant S or S antigen positive, the direct bilirubin should be 0.3 or less. Something above 0.4, you're worried about liver dysfunction.
Thank you. Operator, are there any live questions?
Oh, yes, we have a question now in the queue, and the first question comes from the line of Mr. Glenn Dickey. Sir, your line's now open.
Yes, Bob. I wanted to ask you any data regarding those who are immunosuppressed with biologics, with transplant or HIV, otherwise immunosuppressed, what that does to the levels?
That is a great question. I don't know of any data. I'm going to inferentially predict that the quant S levels would go up with reactivation like you would see with HBV DNA, but that is room for research. And reactivation is a super hot topic now, as you know, especially because we've seen hepatitis B reactivation with hepatitis C treatment with our new DAAs. So sounds like we got some good research ideas out of this presentation today. Thank you.
Super.
Thank you. And at this point, we have no questions on the queue. Once again, participants, if you would like to ask a question, you may press star and then 1. You will be prompted to record your name. And to cancel your request, you may press star and then 2. Thank you.
Okay, we do have many more on the Q&A and the chat. Dr. Gish, could you get a definition of an ALT flare?
Fantastic question. So AL increasing 2 times baseline or 5 times baseline is the window where you start speaking of an ALT flare. So let's say that somebody's baseline is 100 and they go to 200, that would be considered an ALT flare. That's a doubling. Now, the lower your baseline ALT, a little higher threshold. Let's say that your baseline ALT is 15, a doubling to 30 is not going to get you too excited, but going to 75 would be a major change. So the lower the ALT, the higher the multiple, but a 2 to 5x change in your ALT would be defined as a flare. Now, flares are different. You can have just an ALT increase and no change in liver function, but you're going to want to monitor anybody with an ALT increase and take a look at their bilirubin and, most importantly, their direct bilirubin level.
Thank you. Here's another one. Thank you for the great presentation. I'm still having a difficult time deciding why I would want to use quantitative surface antigen levels instead of HBV DNA. Can you explain once more why I would want to use the surface antigen levels when monitoring my patients?
So this is a great question and one that we really want to highlight. We're not replacing HBV DNA. HBV DNA is a foundational test in your initial assessment and your monitoring of patients. So we're not going to use the word instead of, we're going to use the word complementary. So in somebody who's got an HBV DNA level of 200 or 10,000 or 1 million, that Quant S antigen at baseline can help you decide what phase of disease they're in. Next is, most patients with hepatitis B, you're going to plan to start therapy. 60, 70, 80% of patients fit treatment guidelines that have been published by AASLD or EASL. Once you start therapy, you need to see if they have a declining Quant S. How do you determine if you have a declining Quant S if you don't have a baseline? So right now we've talked about phase of disease, baseline, and getting a baseline so you can see what's happening on treatment. So I think these are two important complementary tests. We're not replacing HBV DNA. We are improving and refining and becoming more granular in how we're managing our hepatitis B patients. Really state-of-the-art.
Thank you. One last check, Maisel. Any live questions?
Yes, we have 2 questions in the queue, and first one comes from the line of Mr. V. Camino. Ma'am, your line is now open.
Hello, hi. I work in a renal dialysis lab, Spectra Laboratories. We have a hemodialysis patient that had been had hepatitis B surface antigen positive results since 2013 up to December of 2016. We test this patient monthly. In January 2017, we've gotten a negative result 3 times, I'm sorry. And so the patient was taken out of the isolation and was dialyzed. However, the patient went back in February, sometime mid-February, to be positive. So they questioned that negative result. So I told the nurse that the patient is a chronic courier and should still be dialyzed in isolation. And they want to, is that a correct answer? And plus, is there some kind of leaflet or something that you can send to me so I can send it to the dialysis unit that this can happen on a chronic courier patient, especially with immunocompromised patients?
So it's a great question, and my base is that someone needs to be negative for at least a year on sequential S antigen testing, and we're talking about qualitative testing, before I'm going to say they've really had S clearance. And in the setting of the dialysis, they're going to need to be Quant S negative and HBV DNA negative. There could be up to 7% of patients who are S antigen negative who are HBV DNA positive. So I'm going to need a year, at least in a dialysis patient, Quant S negative, HBV DNA negative, before I would move them from isolation to being in the standard dialysis unit. Remember, this Quant S antigen and qual have a sensitivity of 0.05. If the patient's at 0.04, it's going to be negative by the lab testing, but would be positive by more sensitive S antigen testing. And there are more sensitive S antigen tests that are available on a laboratory basis. They're not commercially available yet. So 1 year, S antigen negative, and you have to confirm they're HBV DNA negative to remove them from an isolation dialysis center. There are publications on this. We could discuss that through the Quest portal and potentially get you something that you could use to reference that to your team.
Thank you.
Thank you. And our next question comes from the line of Mr. Thomas Burgess. Sir, your line is now open.
Not knowing the source of the antibody, aka the species of the antibody used in this assay, has there been any data collected on the effect of human anti-mouse antibodies or heterophile antibodies and the quantification of the surface antigen?
That is a great question that we'll probably need to get back to because I think we're at the top of the hour here, and it's quite technical. So I'm going to turn that back over to the medical science team at Quest. They'll get your name and email address and respond back to you with that information. Very, very good question, but we'll probably need some time to make sure we get you an accurate answer.